am who I am. I'm a Midwesterner. I live in California, but don't hold that against me. I'm originally from Illinois and enjoyed my time in Minnesota. But I'm here to share with you some thoughts, and I really enjoyed speaking with you, your group in Nashville and then in Sarasota. It's a very astute group you have, and I have a lot of good questions, and I have great respect for what you're doing. I put this together, optimizing health span. Sadly, too many people in our society, their health span doesn't last near as long as their lifespan, and so the last years of their life is not great. Sometimes 20 or 30 years of bad problems. But what I'm really going to focus on today is really treating very early, very, very early. Some of you know, probably many of you don't know, that in 2017, the American Dental Association mandated that that dentists screen for airway issues. Now, interestingly, if you look at the program on the American Association of Orthodontists program last year in May, only 5 of 237 lectures even mentioned the word airway. And this is out of an article which I wrote for Orthodontic Practice US, and I can give you a copy if you'd like. Having said that, in this article, Ron Harper, who's a PhD neurobiologist at UCLA, talks about how just even slight reduction in oxygen saturation can have a real enduring effect on kids. Now, the whole mantra of the orthodontic profession, after we've gotten into the whole airway thing, is to expand and all that kind of thing. But the fact of the matter is we've been treating since back more than 100 years ago. The orthodontic profession was treating in the primary dentition, and the big deal was really for health reasons, rather than tooth reasons. That, of course, went away, and most of orthodontics today is all about lining teeth up in the permanent dentition. The profession is focused on expansion. But what I'm going to share with you today is that alone is not going to cut the mustard. It's not going to help. In many, many, many cases, it's much more than that. And Guilleminault and Quo, Dr. Guilleminault now passed away 3.5 years ago, but he with more than 400 articles in the refereed literature, very well respected, talks about how that's maybe not going to be enough. So from my perspective, the orthodontic profession has been given an engraved invitation to come front and center and deal with the airway pandemic, but they haven't even opened the envelope to see what's inside. If we look at the American Dental Association, you see an article here talking about the future of dentistry, and that was last summer, and doesn't even mention airway. Here's another one out of August, the very next month. There's no mention of airway. They're talking about, lots of other things. But I'm here to plead with you that we all need to assume a role in the airway pandemic, and it is a pandemic. So there I am growing up, a little kid in Champaign, Illinois, and here I am in Vermont this January with a longer face. And so we're going to talk about how do you get a longer face. It's not a good thing, by the way, both appearance-wise and health-wise, and we're going to talk about that. And we're going to make a big pitch for treating in the primary dentition. So here's a child who comes to me for one of the many reasons. Second opinion. Orthodontist says, take out 4 teeth, bicuspids. I was taught to do that in Minneapolis. I did it for years. 40 years I haven't. And so I say, no, we don't take out teeth. We're going to line your teeth up for you. But by the way, you need to become a nasal breather. You need to do myofunctional therapy. So we do our thing, line the teeth up without removing any. That's nice. That's easy to do. But that's not the focus. Why am I presenting it? He's still a mouth breather. He still hangs his mouth open, and his face falls back even more. So when you look at him, there he is, and you say, well, he doesn't look that different than a lot of other kids, does he? But that black line is the Bolton norm, showing how far his face has fallen back, and we accept that. We accept that. So here is his mother with her cell phone taking a picture of him sleeping on the couch, and he's snoring, and that's not okay. Because in reality, he has sleep apnea, and he's a teenager and he's got sleep apnea. And that's his airway, which is very small behind the soft palate. And there's no quick fix for that. So some of you may say, well, put him on a CPAP machine and he'll be fine. You know, everybody's got a CPAP machine. Everybody knows about that now. They're advertised on television. But the fact of the matter is the research out of the New England Journal of Medicine 7 years ago, or almost 7 years, talks about that does not protect him or anyone else from having a heart attack or stroke or all the other horrible chronic diseases known to man that are associated with sleep apnea. So it's not a very good solution. John Remmers, who's one of my heroes in this thing, talks about how it's all about if we had the face grow forward the way it was supposed to, like our ancestors, we wouldn't have the problem in the first place. When I heard him speak, it really inspired me about 20 years ago. But then we got this old study from now, it's an old one from 2012 from Karen Bonnick, talking about how so many kids that have these issues, they're filling up the classes needing special education. But in reality, if you go back and look into the 1800s, they didn't talk about that as special education, but they made references to that very issue more than 100 years ago. We've known this. So Phil Cooper from Savannah, Georgia, a good friend of mine, has this book out, Why African American Children Can't Read. It has nothing to do with the color of their skin. It has everything to do with the fact that they have brain damage, many of them by the time they even get to first grade to learn to read. And it doesn't matter if you're white, black, green, purple, it's all the same. If you've got brain damage, you're going to struggle. And we can't allow that to happen. There are other issues here of health that are associated with poor breathing in kids. And here's some from the Gozals, who are very, very well known. David Gozal is a past president of the American Thoracic Society. And he talks about how you really need to get in and treat right away. Forget about waiting for all the teeth to come in. It's way too late. And my hero, Ron Harper, talks about these issues here that are where you're getting permanent damage for these kids. So the point here is it is about Healthspan and not about the teeth, and we need to get back to that. Here's one final one. I really like this one out of 1909, Dental Cosmos, and you can read the whole thing there, but it says, even the brain development is retarded. Wow. And why are we not dealing with that? What happened between 1909 and now? Why are we where we are? A lot of different reasons. So let's show you someone that I think really is a great poster child for why we need to prevent. Here's a gentleman who's in his 20s, late 20s, and he comes to me. He's got a mandibular advancement device, but he still snores with it. And if he doesn't have it in, he's worse off, and he can't deal with the CPAP. He's done everything possible. He's tired all the time. Well, look at you can't see his eyes, I blocked them out. Trust me, he looks tired. So when I said to him, well, you've done everything conservatively, meaning non-surgically, I said, the only way out of this for you is surgery. He says, fine, when do I get started? He's desperate. But when you look at him in his airway, that's an airway that you don't become a grandfather with. You don't become an old man with that. Untreated sleep apnea is going to reduce someone's time on planet Earth by 20%. And that is a horrible airway. So, but you look at him and you see his face is back, but look at him, there's a zillion people like this in your practice right now. It's not like he's an outlier. There's a zillion like him. Now let's look at drug-induced sleep endoscopy that he's having done. Watch this. They've put him to sleep and they're doing fiber optic to look down his airway to see what's collapsing. And you can see him struggling to breathe, and that's pretty gross, isn't it? But that's what it's like for him every night. That's his life. And if he doesn't change something, he's not going to be an old man. So I look at that and say, that's an emergency. That is an emergency. That's an orthodontic surgical emergency. So let me show you another patient just like him that we treated. Here's a gentleman who grew up in the Philippines, and when he came to see me almost 10 years ago, he'd had these upper teeth taken out, and he thought I was going to grow his face forward. I said, I can't grow your face forward. But I took his blood pressure, and that's what it was. And I looked him square in the eye, and I said, you're going to die if you don't do something right away. You need a sleep test, you need it now. And the cardiologist hadn't even asked him if he snored, didn't even suggest a sleep study. So I suggested a sleep study, and he heard me. He got it done 2 days later. That's the results, AHI of 53.3. And when he desaturated to 65%, they woke him up and sent him home. Why do you think they did that? They didn't want to have him have a heart attack or stroke right there. He told me that later. So we did a really interesting thing. Look at him and see how far back his face is. But that his airway is better than a lot of people in this room, but he still has problems. And notice his flared lower incisors, he has no overjet. So I came up with a very interesting treatment plan for him, and we'll show it to you. We're going to take out lower bicuspids, which I never do. I don't extract teeth, haven't for 40 years. But I had to take out teeth, and we're going to surgically set those 6 front teeth back to create an overjet so that we could advance his mandible, we could advance his maxilla, and also could bring his chin forward to make him look better. And that's all of it's being done right there at the time of surgery. You can see that. But that's not what we're all about. This is what we're all about and why I'm showing you this. 10 days post-surgery, he emails me from St. Louis, where the surgery was done, with that information, that his blood pressure had immediately started to go down and has remained down ever since. So that's his airway went from 135.8 to 355.3, and I wish I had that airway myself. So you see his face came forward surgically. That's cool. Can we afford that for everybody? Not really. So when he knew I was going to retire, he drove about 2 hours to come and see me and thank me. There he is in the office back in November, and I retired at the end of November. He just wanted to talk and thank me. But even better than that, just in February, his mother from the Philippines sent me that text message. And that means a lot to me. It means a lot to me. But the real story is here. Look at him on Facebook when his dad passed away. There are pictures of him when he was a little kid and when he was a teenager, and his mouth is hanging wide open. And my point to you is, if he'd had his lips together in a nasal breather, his face would have grown forward, not down and back, wouldn't have needed this at all. What about treating the little boy when he's there as a little bitty kid, and he wouldn't need all of this? The point then is, both of these patients you've just seen, the seeds for real problems were sown a long time ago. So your practice has these people in there just like every other practice. If you haven't asked the right questions, you don't know that. So the point is, how do you develop the face forward? What can you do here? Are there things that you can do realistically to help? Or do we just have to sit back and do surgery for everybody? Well, let's look at this girl here. Doesn't have any real crowding. She's in the early mixed dentition. There's no real compelling reason to treat her. So here she is. You can see her lips are apart, hanging her mouth open, chronic mouth breather. And if she doesn't do something, her face is going to melt away and fall back. And I'm going to show you that in a few minutes with some other patients. So here she is with her 4 upper incisors in, and now I can treat. What I'd really love to have done was seen her in the primary dentition. And we'll show you that too, treating in the primary dentition. But in doing this, what are we going to do? We do something that is literally sacrilegious. It's heresy, to push the teeth forward into their proper position in space, in her face. So look, we create an overjet. And then we bring her mandible forward like this with an appliance that doesn't have a headgear effect to retract the whole thing. And it's possible to do. And we help her learn to keep her lips together and breathe through her nose and have proper rest oral posture. Something that I didn't even hear about until 1990. I wouldn't have known what those words meant. Teeth together, tongue to the palate, lips together, breathe through your nose, rest. So you see what happened in bringing her forward from where she was to where she is. But the real thing here is look at the improvement in her airway. An airway that is a great airway you could basically die with. That 13.1 millimeters squared is not a good airway. We'll look at, by advancing both jaws, what we were able to get for her airway. And that little girl turns into that girl with the cowboy hat on, and she competes all over the United States. She lives in Seattle and flew to Los Angeles to see me for this treatment. Here's another boy, though, referred to me from Chicago with Pierre-Robin sequence, sleep apnea and failure to thrive. The failure to thrive is probably due to the fact that he's getting little or no growth hormone secreted because he's not sleeping well. So that's his airway that we treated by advancing both jaws and expanding laterally. And so the cross-section improves dramatically. And Steve Sheldon, who's now retired, was the person from Leary Children's Hospital who referred him to me. He calls me up one day and said, "Oh, Ryan's done with sleep apnea." He was very happy. And in his book, Kevin Boyd took the case and published in Steve's book, showing this very case right here, and there was no sleep apnea. So I wanted to do a long-term follow-up, and the family had left Chicago, and I went on the internet to find them. I knew they'd moved to Colorado, and this is what an email I got back from the mom after I contacted her. And I love this picture, because there he is with his sister, and she says he's an aggressive tennis player, doing well in school and all that. My question is, what would have happened had we not treated him in the primary dentition? Would he look like that? Would we know? I don't know. But doesn't it make sense that we were able to eliminate that for him early on in his life? Pretty cool. So some people say, well, there's no science behind what you do. Well, excuse me, there's plenty of science. This has been out there since 2007. The airway improvements with this approach. 31% at the dorsum of the palate, 23% here, and 9% down there. It's pretty cool if that's your kid. Notice that's a class 2 patient. And this patient that on the left-hand side was class 2 with the big overjet. And what did we do? We advanced the upper teeth, and then we advanced the mandible. And that's how we got the airway open. Now, those are all averages. And that person where I show this, those airway improvements are massively better than that. We, by the way, never, ever promise resolution of one symptom for anything, or never promise an improvement in the airway. Last thing I'm going to do is do that. So the mantra in our profession really is about expansion and expansion and expansion, and that's fine. I like to expand, but I'm going to share with you it's not the be-all and end-all. And there's nothing against an Alpha appliance or any other appliance. I'm just showing you this kid has got massive expansion in the primary dentition, but his face is already back and falling back more. Here's somebody else in their teenage years with a massively 43 millimeter intermolar width, a lot more than my intermolar width, and probably a lot more than almost all of you here. And yet, she doesn't awake well rested, she's fatigued, and she snores occasionally, and she wishes her chin were forward. Good luck. It's not going to happen without surgery at that age. And her airway is bigger than most in this room, but she still snores. Her brother has an even wider arch and likely has apnea, and that airway is very likely to have apnea. And his face is back, you can see that dramatically, and he's not an outlier. You have people in your practice that look like this. And what's going to happen to him in 20 years? Will he be an old man someday or not? I don't know. I wouldn't put my money on it. I think he's going to have issues. I think he's probably got issues right now. And isn't it sad when it takes a camp counselor to diagnose sleep apnea? Where was the pediatrician here? So this patient got to me because they'd been diagnosed by a camp counselor who noticed the kid stopping breathing all night. He's too late for me to do this orthotropic thing to develop everything forward. So all we can do is expand both arches, which, by the way, I didn't learn to do in orthodontic training. I was taught that you couldn't do that. You wouldn't want to expand the cuspids ever. I routinely have been expanding patients since the middle 1980s. I have a 47-year-old son who turned 47 this week. When he was 8 or 9, we expanded him, and his brother, and my grandson, and my wife, who's here. We expanded her again, too. Wow. It means she hasn't lost her teeth yet? No. She's still married to you, too. I don't know why, but she is. So here he is, and you see how far back his face is, but he's not an outlier. So, and that's an airway to die early with. That's a horrible airway. And in cross-section, think about trying to breathe through that. Think about being at the bottom of a swimming pool and trying to breathe through a cocktail straw, which is kind of what that is. What's going to that do to your brain? So we expand him. It's all I have in my bag of tricks, and he still snores. And his airway got pitifully better, big deal. But so I put him in an appliance to advance his teeth, advance the incisors. Now, a case like that, I learned to take out 4 teeth. And there's zillions of people today would take 4 teeth for that child. The last thing in the world is going to help him. It's going to make him worse, if he could be worse. So we advance, and his mother's really happy. The kid's not snoring. She doesn't hear him stop breathing. But the fact of the matter is, he has a problem still. He got the sleep test done, and he still has problems. So we can't deal with that. You can see how far back his face has fallen over this time, even though we expanded him, because we never learned to keep his lips together. He still hangs his mouth open most of the time. So he's fallen way back. So from the refereed literature, Christian Guilleminault says expansion may not cut the mustard for these patients. And I've said this for years. You cannot expand your way out of an anterior-posterior problem. That was at an AACP meeting in Salt Lake City when Christian Guilleminault was speaking. That kind of came out of my mouth. I was sitting in the back row, because I always do. Don't want to get too close, you right? It's scary up there. You're brave. I'm in the back row. I leaned over and said, you can't expand your way out of an anterior-posterior problem. It's a friend I had for years. And I thought, wow, that's good. I like that. I didn't think about it. It just, boom, happened. So you got to have both, lateral expansion, but you got to get it forward. That's the big deal. So let's look at some father-son routine here. Here's a dad with an airway like that, and he's got sleep apnea. And so now he doesn't have airway problem because he has double jaw surgery to bring his jaws forward. And see how much further forward his jaws are? And now he's got no apnea. Let's look at his kid. Now, that's a case I'd have taken out primary cuspids for at the University of Minnesota. That's what I was taught to do. Then I'd have taken out first buys. But we're waiting for teeth to come in. Here he is with his teeth, his 4 incisors are in, and we're going to do the same thing. We're going to carry those teeth forward and then bring his mandible forward. And look at that pitiful little airway he starts out with. Kind of like his dad's. But look what happened between the time we saw him until he got his incisors in a year later. Think about what we might have done had we gotten to him even earlier in the primary dentition. So here we get him forward, and you can see his chin comes forward like crazy. His face is nicely forward, even at treating at that age. Now I compare him to his dad. Look at his profile there, and look at his dad. I think he's set up better. I'm not going to guarantee this, but he's going to be fine shape when he gets to be an old man. And I think he will be an old man. Can't guarantee that. There are no guarantees in life. How about this gentleman? His face is way back, and by the time he's 40, he's got the usual thing that everybody gets, some stents in their arteries. It's like rite of passage, right? How many people know people who had that done? Everybody does. Here's his son, super deep bite, totally recessed, and his sister's doing orthotropics, and I say to the mom, he needs to do it too. And she looks at me and says, he'll never do it. He'll never do it. And she was right. He wouldn't cooperate. I knew that. So we had to wait for those teeth to come in, and he didn't get them in until he's almost 11. Gets his 4 upper incisors in. Now look what happened from age 5 to age almost 11. See how far back his face fell in that time period. This is critical. He fell way back just like most of your kids have and most of your grandkids are. So here we are. See how much we were able to get him forward with orthotropics starting at 11. That's nice, but it's not that great because he still didn't get his oral posture corrected and his face is back. It fell back, which is not okay. We don't want it to fall back. And now we compare him at age 18 to his dad. And that doesn't look so good, does it? He's back pretty far. And if his face is back, then his soft palate is back. If his face is back, his chin is back. If his chin is back, his tongue is back. So I don't necessarily have to take x-rays to show you that, but in general, you're going to find that's the case. So what if we were able to start him back in the primary dentition there on the left-hand side rather than where we did? That's the whole point. That's the whole point of this lecture, is that we need to start early. And if we don't start early, then we're, it's like starting a lap behind in a 4-lap race, and you're going to run the mile, and you let everyone else start a whole lap before you do. Not going to work out very well. So I happen to believe that mama bears are going to change the world. And this mama bear was someone who'd had 4 teeth taken out, and I reopened her extraction spaces for her, got rid of her pain pattern, got rid of her sleep pattern, and she was happy to have me do anything I could for her daughter. And so here we have her daughter, and look at that bite relationship that she has. 100% deep bite, and for those of you who do TMJ treatment, pretty much this is a girl, she's an accident looking for a place to happen. She's going to have TMJ problems. But more than that, with these teeth like this, her face is going to fall down and back more and more and more and more and more. And she happens to live about 3 hours away from me near San Diego. So the upper teeth are already back about 13 millimeters. That's a lot, isn't it? And if she's left alone, it's going to fall back even more. So if you see her here, I mean, that's her smile. The gummy tissue, the gumminess of her smile is because her upper teeth are clear down and back. All you're seeing is the gum tissue. The upper teeth are below the lower lip. That's how deep her bite is. Now, we could sit back and do nothing and wait for them all to come in. But what did we just show you? And you see her back a little bit with the Bolton norm. So notice she has no resorption on the roots of the upper anterior teeth. Now I can comfortably take them and push them forward like crazy where they're supposed to be. Now just imagine what she looks like when I do this. Go from here to here, and they're out like 12 to 15 millimeters. That's scary, isn't it? But if she wears an appliance to develop the jaw forward, then you get a nice result. And so here she is with her jaws forward, no gummy smile. Here she is, age 12. She hasn't had any appliances in at all, which is kind of cool. So the gummy smile goes to a regular smile, and by the way, she's in a second phase of treatment to line the teeth up. If I were to treat her again, I would expand her arches and get rid of the crowding. I didn't do this. I started her many years ago. I started treating in the primary dentition about 20 years ago, but I never came out of the closet to tell people about it because I wanted to make sure I had really good long-term results. I don't want to be the guy who go see one, do one, and teach one. No, that's no good. I went through enough continuing education courses back in the 1980s where people did that, and then I realized, wow, that's what they did, but they didn't admit it. So, Mama Bear, I love this shirt here. And she drove her 3 kids from down near San Diego. How many of you know the 405 freeway in California? It's legendary, isn't it? It's the reason you go to Burbank, to fly out of Burbank rather than LAX, is to stay off the 405. And people who survive the 405 to come, you know they have a reason, because she's driven past hundreds of orthodontists to see me to do this. So here's an email that I got back in September from one of the people who was in my Echo mentorship from Texas, actually. And she's distraught because the orthodontist she's taken out teeth on the lower bicuspids for this orthodontist for this patient, but the child has already had a stroke. Already a kid had a stroke. And she knows taking out more teeth is not going to help the situation. So what does she want to do? 65 to 80% of stroke patients have sleep apnea. So here's the kid, and you can see the X's are on his bicuspid teeth that they want to. This orthodontist wants her to take out. You can see over on the lower that indeed teeth have already been taken out, and I used to do that. But this is his airway, which is 48 millimeters square. Now, if he's an adult, David Hatcher of Beam Readers has a study out there. Anything less than 60, I think it's 52 millimeters square has high risk for sleep apnea. From 52 to 110 is moderate risk. Above 110 is reduced risk. But the fact is, let's look at something else. Look at where the x-ray was taken. He's end-on-end incisors. That's where he is right now. The mandible is way forward when the exposure was taken. So if his mandible were back where it's supposed to be, the airway would be even smaller. This is a pitifully small airway for somebody. And the fact of the matter is, many kids who have an airway like this, if you try to take an exposure with them, you put them in the machine, okay, Johnny, close your teeth together, like that. By the time you take the exposure, they've pushed their mandible down and forward. Why? Because they can't breathe in that position. And you think, oh, poor attention span. Close your teeth together, Johnny. He can't even remember that for 5 seconds? No, he can't breathe. He needs his mandible forward. So getting an exposure like this is not a surprise. So I want to show you, okay, a similar case that I treated years ago. And believe me, I've taken out 4 teeth on patients like this back in my former life. But I'm not going to do that here. You can see crowding in both arches, and this kid was going to have 4 teeth taken out, enucleating the teeth on the lower because they couldn't dare let them come in crowded, right? So I say no, and so what do? We give them a removal appliance and say, wear this thing, and it's going to open up space for the cuspids. And we do the same thing for the lower arch. And so here you see we've created space in both arches with a removal appliance. Just like that. You can see space for the cuspids. Then, with essentially 52 weeks plus 2 is 54 weeks of braces, the teeth line up, and he goes from the narrow smile on the left to the big, broad smile on the right, and you say, that's kind of nice. And his face, you would have thought, oh my gosh, I would have pushed the teeth way out there and he'd have a big full face, which he does not have. Even after all that advancement, he still doesn't have a full face. But do you think he has more or less room for his tongue? Do you think he has more or less room for air to get through to his lungs, to run that machine to his body and his physiology? Is it going to be better? Figure it out. So I love to show this. It'll get everybody's attention because there's not anybody, at least with any kind of gray hair, which I have plenty of, and there's a few of you who have too, doesn't know Jay Leno, and they all know that Jay Leno's got a big lower jaw, right? Wrong. Look at the Bolton norm on Jay's face. And I had to work to find this. I got it on the internet, a profile. You don't get profiles very easily. But you can see my patient right there and Jay look pretty darn similar, don't they? Really quite similar. And everyone in dentistry knows that Jay is class 3. And everyone in dentistry knows that means your mandible is too big. Am I right? Right. We learned that. Oh, the mandible grew too much. In reality, in class 3, both jaws are usually back. In reality, Jay Leno's lower jaw is indeed farther forward than most class 3 patients. Most class 3 patients will have the mandible even further back than Jay. So here's my friend who's referred to me. This guy's brother-in-law is a dentist on the East Coast, and he was at a meeting where another friend of mine, a dentist from Pennsylvania, referred him to me. Because he knew this guy. He said, I know you've got apnea, and you need to see Bill Heng. So the guy's from Florida, actually. So he'd had 4 teeth taken out as part of adolescent orthodontics to make his teeth fit and eliminate the need for class 3 surgery. I call that making teeth fit on jaws that do not fit. It never works out well. It didn't work out well for him. It doesn't work out well for anybody. Notice the posterior open bite. Where is his tongue supposed to be? He has no room for his tongue. His maxilla is massively back, just like Jay's maxilla is massively back. And by the way, I would strongly suspect that Jay Leno has sleep apnea. So, my friend here lived on coffee, and it was great when he finally got a CPAP machine, but he felt better. But we just showed you from the New England Journal of Medicine that's not going to prevent him from having a heart attack or stroke. Now, why am I even presenting him? Well, because it's a good story. He goes from this airway, which is high risk for apnea, and he knows he has apnea. We do our thing. We open up his spaces where he's had the 4 teeth taken out. Now, post-surgically, he's going to have enough room for his tongue. He can actually get his tongue where it's supposed to be, to the palate. We don't leave him with a squirrely little maxilla with a 26 millimeter intermolar width. We want it to be in the high 30s or low 40s. And that's exactly what we do by preparing him orthodontically for surgery. Here he is after the surgery, and the surgeon who did him was my friend in St. Louis, Rezimova Head. And you can see how much further forward he is, but both jaws have been moved forward. But the chin was reduced so he doesn't look like he's too prognathic. And here he is. I took the braces off. I haven't seen him since because he went back to his brother. He lives out of state, and his brother's out of state. And I haven't seen the finals, but he's been restored. But you can see how far forward his face was brought. And that's not what I'm here to show you about. It's not about his profile. No, 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 no. No. Yeah, he looks better. Okay, fine, he does. But that's not the whole point. The point is his airway has improved dramatically. But just improving the airway doesn't necessarily mean that his physiology is going to change, does it? But let's look about his physiology. How has it changed? Yes, his smile is better after his treatment. This is the take-home message for you. So shortly after he came back after the surgery, he reported that he doesn't wake up after sleeping for an hour in a total sweat, which means he's in, sympathetic overload, trying to survive, stopping breathing all of the time. Then he went to get an eye test, and his ophthalmologist says, gee, you got better vision. You don't need glasses that are as strong. Well, what did you have done? Well, I had my jaws brought forward to get rid of my apnea. And she says, oh, must have changed the shape of the eyeball. Who'd have thought? I'm just a dentist, an orthodontist. I was 15 when I decided to become a dentist rather than a real doctor because I didn't want to worry about people living or dying. And here I am worrying about people living or dying. This is the real reason I showed this to you. He walks in about 6 months after the surgery and announces this to me. I'm the healthiest I've been in my adult life. At age 25, his cholesterol was through the roof, and it's been over 400, whatever. You can read it. And he's super happy. Now, is he going to live forever? I don't think so. Nobody's going to live forever. But is he going to have a healthier life for however many years he has? I think so. So we show you a class 3 patient who's had both jaws moved forward surgically. Do you think maybe it would have been easier to fix the problem early? So here we have a class 3 patient who's a restless sleeper, got a wet spot on the pillow, hanging his mouth open. And I would have a wet spot on my pillow if I didn't tape. I've been taping my mouth shut for 11 years now. I went 3.5 years without a cold because of that. I highly recommend it. So, and the mom actually hears him gasp occasionally. And if you hear a kid gasp, they're gasping because they stopped breathing and now they're starting to breathe again. That's apnea. And if that happens even once per night for a child, that's considered sleep apnea for a child. They stop breathing for more than 10 seconds. Very different than for an adult. So we do our expansion. We use a face mask to advance the maxilla, get them out of the anterior crossbite at age 7. We could have done it even earlier if we'd have seen them. So here it is after no appliances at all for 3 years and the teeth are falling in place. Is he even going to need orthodontics? Probably not. Look at that. So there I am building a stone wall at our place in Vermont where we used to live. And honestly, building a stone wall is hard work, but advancing the maxilla, pretty easy on a kid like that. If you put a face mask on a child at that age, you can really launch their maxilla forward. It's like a maxilla is anchored in jelly. It's really, really easy to move. Age 10 or above, it's harder. Age 15, oh, good luck. When you get a child, when they got all their permanent teeth in, and you go to try to correct the problem at age 12 or 13 to try to correct an anterior crossbite, with a face mask, you're not going to get the kind of result. If you put a face mask on a 4-year-old kid, get out of the way, you're going to launch the maxilla forward. It will go like crazy. So there I am in the sandbox in Champaign, Illinois. I had no idea there that I would someday be a dentist, but I'm still not much different than that. I'm still a little boy, and I'm still this, guy who wants to do the right thing all the time. And I think we can change the world. Everybody in this room is part of that. You could be doing something else. You don't have to be at a continuing education seminar in Dallas, Texas. You could be home doing whatever you're doing, but you're here, which is great. What I say is, we got it even better. We don't even have to do it. We just got the mama bears to do it. All we have to do is motivate them. And believe me, they are motivated. When I see my daughters-in-law communicate on their cell phones with their mommy friends, man, I realize what the world is going to be about. That didn't happen. My mom never used her cell phone, for God's sake. We can change, we can sit back and watch the mama bears change the world with their mobile devices, because that's what they're going to do. The best mama bears are the ones who've had teeth taken out and have been retracted, and they have all the issues that I spent many decades treating. I call them politely train wrecks, and they're hard to treat. But that's what's going to change the world right there. The cell phone in the hands of a mama bear. And all we need to do is to educate the mama bears. That's what we need to do. Then we have to have enough people to treat the kids that are out there that are suffering right now. We've got 15%, that was the last time I saw, of the kids are getting diagnosed with ADHD. And my good friend Steve Sheldon from Lurie Children's Hospital in Chicago said, I don't believe there is such a thing as ADHD. I believe it is always, a very important word for a researcher to say, always. That's pretty tough, isn't it? I believe it is always a sleep and breathing disorder. That's what Steve would say. What do I know? I'm just a tooth carpenter. I'm not a real doctor. So I look at this and say, orthodontics was fine back in the day. Aligning permanent teeth and making them fit like gears, that was fine. That's what I was taught to do. But you're wasting your time listening to me based on what I was trained in orthodontic training. What I'm sharing with you is what I've spent my life doing for the last 30 or 40 years. And I had a long time to learn what I learned on my own, and it wasn't necessarily easy. But I believe what we should be doing is what I've come up with, this ortho to health, and you notice the O2 means oxygen in the middle there. Treating airway in the primary dentition. That's what we need to be doing. We can't focus on whether the lower incisors are straight or not. Who really cares? Who really cares? So, with ortho to health, we have treatment strategies for people from 3 to 103. And we need to, more than anything, we need to recognize it at 3. We need to get that kid to have his teeth together, his tongue to the palate, lips together, breathe through the nose. We need oral myofunctional therapists to do that. And I'm a huge advocate of that and support that, the myofunctional therapists all the time. It should be that by the time they even see the orthodontist, they got their lips together, breathing through their nose. But this stuff has been known since the time of Charles Dickens, back with the Pickwick Papers that he wrote, way back in the 1800s. All of this has been known. There's nothing new. There's really nothing new. And it's not about the appliance. People ask me all the time, well, what appliance do you use? Oh my gosh. It's not about the appliance. It's not about the appliance. It's about knowing what the problem is, why it occurred, why did the problem occur? And very few of your children and grandchildren have proper rest oral posture. Even if their lips are apart a couple millimeters. Even if their lips are together, they may not necessarily have proper rest oral posture. They may have their tongue postured between their back teeth, which allows this to happen. Deep bite, even with their lips apart. they can have this happen. It's not okay. They have to have their teeth together lightly, their tongue to the palate, lips together, and breathe through their nose. That's your goal. So then you have to know, what are the possible solutions? What can you do? What's going to be helpful? Particularly with the adult patients. Let's say you want to reopen 4 spaces, which I teach people how to do. That may or may not solve the problem. Maybe it's a surgical case, and you have to be able to know that. The last thing you want to do is open 4 spaces and fall short. Gee, I'm no better. And here you are, you've spent 1.5 to 2 years, which is very challenging treatment to do. And there is no cookbook, but you're here to learn, and you're intelligent people, and you can and should. So, there I am, retired. That previous picture is a big lie. I don't look that way anymore, obviously. I haven't had a picture like that taken for quite some time. That's the more realistic one. I'm not practicing anymore, but I describe myself as a human doing rather than a human being. I have to be doing something. And so I hope that these ideas I've shared with you today are helpful to you. I'm here to help people, and that's kind of my new thing. And my wife insists that I continue to do this because being around me without me doing something is not so great. Thank you very much. You've been a great audience.
All right.